Thank you very much, dear Mr. Chairman, ladies and gentlemen, dear colleagues and friends. It's a pleasure to be here, and I'll continue in introduction of our work, which is teamwork. One of the leaders of QEEG studies is sitting here and will speak after me. And this part of work is focused on prediction prediction of therapeutic outcome in treatment of depressive patients. There are many circumstances which causes depression to be big suffering, not only for the patient but for families, and also huge societal economic burden for the society. And it means that everything which leads to prolonged suffering, for example, the late onset of the treatment and hesitations in the treatment and finding the right treatment by trial and error way, increases the suffering and expenses for the society and represents a huge individual and social burden. So any intervention shortening the period and shortening the suffering and disability saves a lot, both of suffering and expenses. So it's worth to look for predictors and indicators of the future development in very early stages of the disease. One of these possibilities is the parameter which is called QEEG concordance. This is calculated from quantitative EEG power values, and it integrates absolute and relative power information in the EEG signal. And it's hypothesized that it's associated with the regional cerebral perfusion, which is related to the decreased stimulation of inferior cingulate, and maybe it provides information which is interpretable in the context of pattern-spec neuroimaging studies of depression, particularly on cingulate. For those who are not familiar with the principle of EEG recording, this is native EEG signal without any pathology and combining a lot of frequencies. If you take and process part of the signal, which is artifactless, you can calculate the power for different frequencies which are expressed in microvolts quadrate as an area under the curve. Here you see in colors. You can plot the powers for each particular frequency into the map of brain or map of the head, and you get the maps either showing absolute spectrum and relative spectrum, which shows the proportion of the power for the respective frequency out of the total power. The problem is that absolute spectrum and relative spectrum do not correlate in every instances, and if they go in an opposite direction, it can serve as an indicator of a pathology, for example, of the brain damage. And this is the principle on which the calculation of concordance is based. Absolute, it's recorded from 3 prefrontal electrodes, and absolute power, the value alpha, is calculated from each individual electrode by averaging power from all bipolar electrode pairs sharing that electrode, as shown here on this scheme, showing how the formula is created. Then relative power can be calculated as a proportion from the total, and then both absolute and relative power can be normalized. Normalization means the value which represents the proportion from the maximum reachable, both in absolute and relative spectrum. And finally, the coordinates calculation combines both these parameters in one figure. And this figure is what we follow. And it changes during the course of depression, respectively during the course of the treatment of depression. The papers which are outcome of the research led by from our institute, who is a clinician, where in a series mapping the diagnostic or predictive power of these parameters in different therapeutical settings and for different therapeutical modalities. For example, design of this study shows how the study was conducted, what scales were applied, and what was the group of patients. In this pilot study, you see that the number was quite small, 17 patients who fulfilled the stage 1 criteria for resistant depression according to the case in Flash, and were treated with the group of SSRIs and the novel antidepressants, and the response was defined as equal or more than 50% reduction on MADRS score. And as you see, 5 patients responded and 4 achieved remission. The group of antidepressant modalities was quite heterogeneous, but this is not the problem in this respect. Here you see the development of the parameter which we call QEEG coordinates, and you see that in the group of non-responders, this number slightly increases, while in the responders it decreases. If you take it dichotomically, increase or decrease, you reach the positive predictive value of this parameter, about 70%, and negative predictive value even here was 100%. It means that all responders showed increase of coordinates, while 10 out of 12 non-responders showed increase. Here you see, just to remind how all these parameters are calculated and what do they mean and what is the relationship between positive predictive value, negative predictive value, and sensitivity and specificity. Sensitivity says how much or how many of cases who were caught by the test were really or should be caught by the test, really caught by the test. Negative specificity say how many of those who should be negative really were negative, and ideally the true positive and true negative proportion should be 100%, which is never the case if you apply this evaluation on diagnostic symptom, clinical symptom, on biochemical tests, laboratory tests, EEG, cardiology, ECG, cardiology, and so on. So false negative proportion is second type of the statistical error. We call it Hamlet. You don't see the danger where it is, while first type of statistical error is Othello. Sees the danger where it is not. And if you fill the table with the numbers from our first pilot study, you see what was the sensitivity and specificity of coordinates. The same method was applied in the continuing research focused on prediction in prefrontal theta QEEG in resistant depressive disorder in patients treated with venlafaxine. So the treatment modality was much more homogeneous than before. Conditions were very similar, and here is the result. Again, you see that those who responded showed decrease of concordance, and the other way around. The sensitivity and specificity was only slightly lower than before, and it repeats in other therapeutic modalities as well. So we can conclude that this parameter which integrates absolute and relative power information changes during therapy of depression, and after 1 week it can predict the further development of the treatment response, so that using this information, you can change the antidepressant much earlier than if you are waiting for the clinical effect up to 3 weeks. So that the earlier you know that this particular drug will not work, the better. And this parameter can save a lot of suffering and can save a lot of expenses. So, any intervention shortening the period of disability is valuable. Our hypothesis or suggestion is that the decrease of QEEG concordance might reflect activity changes in cingulate area 25 as depicted using pictures of Helen Mayberg from different studies, just to show you what we have in mind. It's not originally planned as a correlation of particularly this fMRI study. This slide shows slightly different expression of the same results using ROC curves, which show the specificity and sensitivity as well plotted in a different expression. And area under curve should be again 100%, which is not usually. And here, this is taken from one of our work led by Dr. Barish as well, showing that the same predictive power can have very careful clinical observation and careful assessment using, for example, mothers by clinician in the very early stages of depression. And the decrease, the higher the decrease in the first week of treatment, the better response to the respective antidepressant. On the other hand, if we try to compare the predictive power of concordance change in repetitive transcranial magnetic stimulation and treatment with venlafaxine, we didn't find any difference. So you can see on this slide that there is a description of the sample, the average value of baseline mothers and end of study mothers, and the number of patients, 25 on both sides and so on, showing that this parameter is good as well for predicting the therapeutic outcome of transcranial magnetic stimulation as well as using drugs. So it seems that it doesn't reflect specifically the modalities, but reflects what happens with the patient. And that's quite stimulating finding and conclusion, helping us to interpret and to understand this phenomenon. So, I thank you for your patience and attention, and I thank the whole prediction team led by Dr. Barish and Dr. Grunovsky. He's an EEG man, he's a clinical researcher, and others are more or less involved in statistics, in mathematics, in methodology and design of the study, and